To introduce Mal Hopwood, who is going to in turn introduce Professor Allan Young. Mal, the reason I'm introducing Professor Hopwood is that he's the interim head of psychiatry at the University of Melbourne, and he's overseen Professor Young coming to visit Australia. So Professor Mal Hopwood is the interim, as I say, interim head of psychiatry at the University of Melbourne. He is also the immediate past president of the College of Psychiatrists in Australia and New Zealand. And has a number of other important positions, including Professor of Psychiatry with Ramsay Healthcare and Clinical Director of the Professorial Psychiatry Unit at the Albert Road Clinic. Has a number of other interests and quite a strong academic history as well, which I won't go through in detail, but Mel, invite you to come now and introduce him.
Thanks, Bill. It's kind of an odd idea, isn't it, introducing someone to introduce someone else. Thanks for that. Welcome everyone. It's actually a great pleasure to be here. So this lecture is part of an activity that the Department of Psychiatry at the University of Melbourne hosts under the Betty Lynch Trust. It's a trust that was given to the university to continue education across Victoria around mood disorders and bipolar disorder, including bipolar disorder, but not limited to. And part of the requirements of that trust is that we bring a visiting professor to Victoria each year. We provide a public lecture which will be held at the University of Melbourne tomorrow night, and I look forward to seeing you all there as well. And we provide a lecture outside Melbourne, basically, anywhere else in Victoria. Allan, who's going to talk today, has come over on a couple of previous occasions, done us the honour, and has been to Geelong and Shepparton. So this year, as the interim head, I was charged with the task of thinking where to bring Allan this year. I spent a lot of time thinking about which psychiatrist could I think of who most needed education, and for some reason John Cooper came to mind. I don't quite know why. So it's a great pleasure to bring Allan to Bendigo, and it's great to be here again. For those of you who don't know Allan is the Director of the Centre for Affective Disorders at the Institute of Psychiatry in London, which forms part of King's College. That's a leading affective disorders unit, I think we can say quite clearly, in the world. And the Institute of Psychiatry is one of the leading research and, allied to the Maudsley Hospital, one of the leading treatment centres in the world as well. So to have Allan here to share his insights with us, it's a great thing to be able to bring to Bendigo. I really feel very pleased about that. So I'm going to introduce Allan without further ado, and I'm sure you're going to enjoy his lecture. But before he starts, I almost forgot. I do want to thank Lundbeck and Otsuka for sponsoring today's lunch. Of course, they brought to us brexpiprazole for the treatment of schizophrenia, which is now available, something I'm sure you're all looking forward to trying soon. Thank you, Michelle, and welcome, Allan.
Well, thank you very much for that kind introduction, and thanks for having me back again, Mal. And I must say, we've been superbly looked after on our trip to Australia this time. So it's a great pleasure to be here, and I'm going to talk about the treatment of mood disorders, and I'm going to talk about the current challenges and future possibilities, and we'll just see how it goes. So we can have questions afterwards, maybe. If anyone has a burning question during it, such as where did you get that awful shirt, I'm quite happy to answer. So this is our current classification of mood disorders, and this really came in formalised in DSM-3, DSM-4, DSM-5, and it splits mood disorders into bipolar and depressive disorders. I personally am uncomfortable about there being a silo between bipolar and depressive disorders. Of course, it used to be manic depressive illness, not all of it, but almost all of it. And I think, if you think back to what Kraepelin said that the key first decision was to determine whether there was recurrence. So our pathway in Maudsley is actually called the Recurrent Affective Disorders pathway, and that really maps onto what would have been manic depressive illness in the old days. It's notable that if you look at major depressive disorder, and you look at the epidemiological studies in the community, about 50% of people who have episodes will have one episode only. And that's very different. And that surprises psychiatrists because we don't see people like that, but that's what the epidemiology says. So that's obviously very different from a recurrent mood disorder, which I think is the key thing. And it's one of the weaknesses, to my mind, of DSM-5 that bipolar disorder has a separate chapter from depressive disorders, because already we're seeing people who think in a very concrete and literal way, in other words, Americans, thinking that these are actually very different disorders, and they're not. And one of the great challenges is not only thinking about how to determine which is which, but being aware that they may change. The other point about this is when we think about treatment, we should be thinking across the range. We've been very, very poor in doing this. So we use, for example, antidepressants in bipolar disorder very commonly on the belief that the data from major depressive disorder can somehow be extrapolated there unthinkingly. I wrote an article about this in the Australian and New Zealand Journal saying the solution to this was quite simple. Essentially, if a drug gets a license for major depression or major depressive episodes, it should have to have trials in major depressive episodes in bipolar disorder as well. And of course that article sank like a stone. No one's ever taken any notice of it. But the point remains. So for example, vortioxetine, Lundbeck's new drug, which we've used quite a lot, in Europe has a license for major depressive episodes. Now, major depressive episodes can occur in MDD or bipolar. The evidence for vortioxetine is entirely in MDD. So there's a real gap there in our knowledge base. This is a slide I like to show the students. It's a little bit complicated, but the key thing is the balance between benefits and harms. So benefits being treatment efficacy and harms being adverse effects. This applies for every treatment, and we think about it with medication. We're probably most developed in looking at it with medication. There is a belief among some people that you don't get adverse effects with psychological treatments, but that's clearly not so. Jan Scott and I did a little editorial in the BJ Psych last year because there had been a report from our IAP services of the rate of adverse effects which became evident during psychological treatments in that large service, and it's about 5 to 9%, but that's without systematically looking for these adverse effects. Of course, these are different in nature and character. In psychological treatment, you tend not to get a rash or things like that, but nevertheless, dependency, psychological disturbance are very, very common. So we must always think about this, and we're also actually quite poor in terms of looking at this with devices. We tend to think again that somehow devices, a number of times you hear that neurostimulation doesn't have adverse effects and so on and so forth. So we need to extend the methodology from medication to other parts of the therapeutic armamentarium. We need identification of the actual mood disorder as best as we can. I think DSM-5 is actually very helpful for that. The specifiers where you can look at lesser degrees of mixed states, of comorbid anxiety and so on are very helpful. And we need to think about identification of physical and psychiatric comorbidities. One of the weaknesses of our evidence base is we tend to exclude the patients who actually are in greatest need. So particularly people with mood disorders and comorbid alcohol or substance abuse very often don't get into trials, but they very often represent the biggest clinical challenge. Two more points of note. One is that this is the key requirement for individualized treatment in the average or in the round, but remember it will differ for each individual patient. So you do get some patients who have adverse effects which can be quite marked, but they're willing to tolerate them because of the benefits. I always remember when I was a young consultant, we had a patient who responded very nicely to clozapine, and he had quite pronounced weight gain with it. He had the excess salivation, and the nursing staff were saying, well, perhaps the benefits he's had from clozapine aren't enough to justify this. But the patient himself said, nothing's given me the relief that clozapine has. So you must think about this not only on the average, but also for the individual patient. And the last thing is that we should be aiming for meaningful remission. When we think about pharmacological trials, people talk about response, which is a 50% drop, remission, where you drop below a certain level of depression or manic symptoms. You still have some subsyndromal symptoms, but in actual fact, we want full return to health. Now that's difficult to define, but people know it when they experience it, and that should be our goal overall. So that's a little bit of preamble. If we look at the current treatment options, many of them are pharmacological. I've split them into pharmacological and non-pharmacological. I'll talk about NICE and the view of antidepressants and augmentation in a minute. In terms of non-pharmacological, there is of course psychotherapy of various different forms, lifestyle change, mindfulness, phototherapy, devices. You can see immediately there's a range between psychotherapeutic intervention and really invasive neurosurgery with DBS. Again, all of these have got to be examined in terms of the benefits and harms. But most of the treatment, most of the time, is going to rest on some form of psychotherapy combined with pharmacology. It bears saying again and again that there's no contradiction between having a psychotherapeutic approach combined with medication. You may say, well, of course, no one would believe that, but I see in the clinic time after time patients who've been told by or gained the understanding from the therapist, they may not have been told, that somehow the medication is interfering with getting at the root cause of the disorder. And that's simply nonsense. You're probably better off with both. So this is our NICE stepped care model. Now the eagle-eyed of you will see this is from 2009. The NICE guidelines are currently under revision. NICE, the National Institute for Health and Clinical Excellence in the UK, is extremely well funded. It does things that I think most other people that do guidelines don't have the resources to do. So Mal said you did the Australian and New Zealand guidelines, we've done the BAP guidelines. NICE will actually go back to the original data and redo meta-analyses, which I don't think anyone else does. Certainly the Canadian guidelines don't do that. And they've actually found that some of the meta-analyses are wrong. So so they have this degree of expertise, thoroughness and capacity that other people don't have. Unfortunately, NICE often get it wrong with psychiatric treatments for some reason. And I think that's partly because they are evaluating this without knowledge of the particular context of psychiatric treatments. So I think NICE are very good in some ways, but in other ways we need to be very careful about them. So for example, with ECT, NICE, the initial NICE report, which came out 12 years ago or so, was actually negative about ECT, and very restrictive, which was really because they'd had some very vociferous anti-ECT service groups who'd actually skewed the assessment. So this is the stepped care model. This is worthwhile looking at because this is actually representative of what happens in the community. So you go from step 1 up to step 4. Many of us will be working in the top half here, but you can see there's a range of simple interventions right through to medication, high intensity, and so on and so forth. And this, of course, just speaks to the nature of mood disorders. These are variable, heterogeneous, and extremely common. And we shouldn't extrapolate from one to the other too unthinkingly. It's one of the particular difficulties of working in this area that many people feel that they understand what depression is because you can use the word in an everyday context. But that's something that's very different for many people. You can immediately see that antidepressants for the duration of illness plus 6 months, and those of you who are familiar with the literature will know that that pertains to the first episode of depression, but recurrent depression, which is 2 or more episodes, we don't know when to stop antidepressants. And if you look at why NICE did this, again it was because there was really non-evidence-based pressure, if I can say it that way, to actually limit the use of antidepressants. So their recommendations tend to be influenced by other factors. So there's a plethora of different types of therapy, pharmacotherapy, psychotherapy, neurostimulation and so on, but about 80% of patients who enter into treatment receive some form of pharmacotherapy. So this is what I'm going to major on today. In terms of the National Institute of Clinical Excellence choice of antidepressants, I believe that there's been somewhat of a loss of knowledge because of the belief that somehow all antidepressants are the same. So if you look at the group means, there will be relatively little difference in the efficacy or response, and therefore NICE say it should depend on side effect profile, patient preference, previous experience of treatments, and so on and so forth. And there's a great pressure to choose generic SSRI because that's cheaper. They were actually quite negative about escitalopram. They've actually been quite positive about vortioxetine. Vortioxetine has been approved for people that have failed an SSRI and or an SNRI. But I think there's been a bit of a loss of knowledge and skillfulness in the use of antidepressants because of this blanket approach. For example, monoamine oxidase inhibitors, the irreversible ones, the ones which have been around for 60 years or so, are used very rarely in the UK, but there's particular subgroups of patients for whom they seem to be very effective, as I say, we recently got data showing that there's less than 1,000 patients in the UK on irreversible MAOIs. I'm not sure if they're used more here, but if you actually look, it's used by a few mood disorder centres only. So, not all antidepressants are the same. One of the great challenges for the future will be applying a form of stratified medicine such that we can identify who will respond to the antidepressants. And I believe that there's work in Australia underway. I was hearing about this last night from Professor John Tiller about predictive models that can predict people who will have an 80% chance or better of responding to a particular antidepressant based on various genetic or characteristics or brain pump transporter characteristics. And that would be a great advance. We could actually say, instead of having a 40% chance of this really working for you, it's going to be 80%, that would really move the game forward. We've yet to see that actually really happen though. So if we look at tolerability, which is very important for NICE, they've got a range. They've got the Wellbutrin, this is bupropion. Now I believe like the UK, this is just licensed for smoking cessation here. I spent 6 years working in Canada, and very unusually for an academic, I saw patients. I must say, if you look at the data, Wellbutrin doesn't appear to have anything different in terms of efficacy, but tolerability it certainly does do, because it's got a different side effect profile. So for example, the impairment of sexual functioning that you see with SSRIs, you don't see with Wellbutrin. In actual fact, it actually seems to send the scores the other way. It slightly enhances sexual functioning. And for some patients, there seems to be a very, very good response. So I actually use this as an antidepressant in the UK. And then there's this group here of drugs that you're all familiar with. There's the antipsychotics. Now the antipsychotics are particularly interesting because we think of antipsychotics, or people who are learning about treatment of depression think about this in terms of augmentation of other antidepressants. But there's always been a literature about low-dose D2 antagonists, that's antipsychotics, in other words, being antidepressant in their own right. So the British National Formulary, if you look at flupentixol, which of course is a depot antipsychotic, it comes in a tablet form, and 1 or 2 milligrams of that is an antidepressant. And there's a pharmacological mechanism for that. It's about blockade of your presynaptic D2 autoreceptor, boosting the amount of dopamine in the synaptic cleft. In other words, a similar mechanism to Wellbutrin. There's the tricyclics. Now these have almost stopped being used, except by experts. And there are some of these drugs that are very useful. For example, we still use quite a lot of lofepramine. I'm not sure if that's used here. Lofepramine back in the 90s was the choice between that and the SSRIs, but it somehow dropped out of people's decision frame. It's actually very safe, it's very well tolerated, and it's cheap. The monoamine oxidase inhibitors, as I've said, my own view is that meclobamide is nothing like an irreversible MAOI. I think phenelzine is the go-to drug. Tranocipramine we have particular problems with because it's become psychiatry's most expensive drug. It has been debranded, and therefore the limits to what the NHS will pay have gone, and they will pay £200 per 10 milligram tablet a month. So we have some patients who are on 100 milligrams, and we're paying £2,000 a month, which at the moment is about 2,001 Australian dollars, for a drug that's practically 70 years old, 60, 70 years old. So this is outrageous. But nevertheless, some people need to be on it. The other thing I would disagree with is lithium. I wouldn't disagree with lithium, but I think the idea that lithium is not well tolerated is actually quite wrong. Lithium, certainly in the range between 0.6 and 0.8, is a very well tolerated drug. And also there's recent evidence published in the Lancet Psychiatry, and I did an editorial on this, reviewing the evidence, that lithium is a very good drug for unipolar depression. Tianen looked at, in Finland, where they have the health records for all of Finland, looked at the drug that was associated with the fewest readmissions in recurrent unipolar disorder, and by a long way it was lithium. And if you look at the meta-analyses, the randomized controlled trials, which were done in the 90s by Goodwin and D'Souza, and then a generation later by Cipriani, they all show that lithium is a very good drug for unipolar disorder. And that strikes lots of people as being counterintuitive, because lithium was really for bipolar, isn't it? But I'm lecturing on this tomorrow, so you might hear more about it then. So this is the response level with currently available treatments. STAR-D, I think STAR-D was a very, very good study. Lots of people criticize STAR-D. It was masterminded by John Rush, who I think is one of the doyens of mood disorders research in the United States. And I think it probably accurately reflects the rates of response at different levels of treatment. But first line, for most places, it's SSRI. Second line, adjunct or switch. We used to say that you had to go to a different class if you switch. That doesn't seem to be the case. The only three drugs that seem to have evidence for benefit of extra efficacy are venlafaxine, escitalopram, and vortioxetine. Vortioxetine's got very good evidence from its trials. Third line, adjunctive, switch, and so on, and I'll talk about these. And then we get into what mood disorder centres do. I should say that I view ECT as having much greater efficacy than any of the others of these. So I think ECT is something that we underuse. We wait far too long before giving it. The other one, I know that TMS is popular in Victoria, but I'm not sure it's got that much extra efficacy in treatment-resistant depression. But vagal nerve stimulation, I think, does have some traction, and I think that's a reasonable thing to pursue. Mal and I were talking on the drive up here about deep brain stimulation. Of course, remember, this came in for Parkinson's, where it was associated with depression as a side effect. Helen Mayberg has championed this in the United States. My own view is that the evidence supports use in obsessive compulsive disorder, but 2 trials have failed in MDD. So lots of people believe in DBS for treatment-resistant depression, but the evidence just isn't there. So what do you do when someone hasn't responded to antidepressant therapy? Well, you increase the dose of the antidepressant, switch from one antidepressant to another, you augment with a non-antidepressant agent, or you add a second antidepressant. If we go through this in order, increasing the dose, there isn't really much evidence for the new drugs of extra benefit, with perhaps the exception of vortioxetine. If you look at the vortioxetine meta-analysis, there seems to be an increase with 20 milligrams having an effect size of above 0.8. That's one of the best pieces of evidence for there actually being a dose response curve with an antidepressant. There's not such good evidence for venlafaxine. Switching from one antidepressant to another doesn't seem to be matter what you switch. In the UK, GPs do this endlessly, and some people will respond. In terms of combination, if I can skip to the end, the COMED study done by John Rush shows that there's little benefit for combining antidepressants. So this is a large study with about 200 in each group, combination antidepressants versus monotherapy. No significant difference. In the straight numerical terms, I think the best result was with monotherapy escitalopram. There's a nice meta-analysis from Tom Bishar in Berlin, which looks at all of the data, and the only benefit is if you combine mirtazapine with an SSRI or an SNRI, or mianserin, which is not very commonly used. And then the benefit isn't particularly great, large. So adding a non-antidepressant agent, which tends to be lithium or an antipsychotic, is very commonly done. So in terms of adjuncts, people use antipsychotics, lithium, and then the evidence base runs out, and I think these are the two that we should be looking at most. All of the antipsychotics in low dose seem to boost the effect of antidepressants. So we've seen the license for this being given to quetiapine. In the United States it's given to aripiprazole. Brexpiprazole, again in low dose, has similar good trial data, but there's evidence for all of these drugs doing it. Again, I think it goes back to the presynaptic D2 mechanism. People always think of D2 as being postsynaptic and blocked by antipsychotics and psychosis, but if you block the D2 receptor presynaptically, which needs much lower doses of D2 antagonism, you boost the release of dopamine, and that's what gives you the extra effect. So currently, Professor Tony Clear and myself are doing a trial of people who haven't responded to antidepressants, who are then randomized to either quetiapine or lithium. This is the LQD study. Like everything else, it's going to take about 3 years to do. There's problems with recruitment and so on and so forth. But this should actually give us some idea of which is the best option in terms of which one to choose. So this is the STAR-D study, Tremedi, Rush and so on, the sequential response to treatment. Many people thought that this was a very depressing result for the field, but I think it's pretty realistic. More than 40% of patients still have unresolved depressive symptoms following treatment attempt. And what happens is that with each subsequent treatment attempt you get less return for your money, but remember you still get some benefits, and this is a key point in mood disorders. Some people will respond at each stage, and if, like myself, you're often on the 15th treatment attempt, you still see some people that respond to that, and that's a very important message to give to patients. So the advantages of adjunctive therapy: it builds on partial success of first therapy. You avoid washout. I mean, one of the problems, for example, of putting people on irreversible MAOIs is that they're a real hassle. You've got to take people usually off the previous drugs for a period of time drug-free. For fluoxetine, that's probably 6 or 8 weeks. Meanwhile, the person's getting sicker, and then you add in the MAOI. So adding the therapy is much easier. And when effective, benefits can be quite rapid. If you look at the trial evidence base for adding atypical antipsychotics to antidepressants, most of the benefit occurs in the first 10 to 14 days. And you can choose the treatment to target specific symptoms. So in the UK, even though aripiprazole isn't licensed for this, our two choices for augmenting antidepressants in terms of atypical antipsychotics are quetiapine or aripiprazole, and that's tailored to whether the person needs sleep or needs a drug which is less likely to promote weight gain and somnolence. Now, there's a very interesting story about folate. There's a big trial, and there was a meta-analysis of small trials suggesting that folate had very clear augmenting effects on antidepressants, and that was particularly pronounced for women. I don't think it made significance for men. And it became part of guidelines. I don't know if it's part of your previous Australian guidelines, that you would give folate. And then a group in Wales, Tranter and Healy, did the folated trial, where they actually did a far bigger trial than anyone had done before, and there was no result. So if you add this into the meta-analysis, folate clearly isn't an antidepressant booster. It's a nice case example of evidence of the pitfalls of evidence-based medicine, that you shouldn't gain a definitive answer from evidence that's really not fit for purpose. And what you really need before you conclude anything is a big trial. Now, folate is metabolized to L-methylfolate. People say that the reason that folate doesn't work is because there's a problem with that step. And there's, again, similar small trials using L-methylfolate as an augmenter. I've shown you one of them here. We actually use this in the clinic. It's very difficult to get hold of methylfolate. I don't know if you've been able to do that here, but certainly we've got reasonable results with it. But again, this could go the way of folate. A large trial might reverse it. At least there seems to be tolerable adverse effects with methylfolate. But I really put it up as a case example. So here's the meta-analysis of response in double-blind placebo-controlled augmentation trials. These are people with major depressive disorder who haven't responded. You add in low dose of the atypical. So we're talking about 50 of quetiapine, 1 to 2, sometimes in the elderly with aripiprazole, I add in less than 1 milligram in liquid form, and you can add it in every second day because of the long half-life. You very often get an enhanced adverse effects from even from the low dose. But you can see all of these seem to work. This is really a very robust evidence base. My own particular prejudice, I'm afraid, is against risperidone. I think certainly in higher doses this is almost pro-depressant, but I do have some patients on very low dose risperidone as a booster. But of course, remember the side effects pertain. Mal and I were talking about the high water mark of Seroquel and quetiapine when they were very present in psychiatry. They were doing lots of trials. Quetiapine's actually been a victim of its own success, certainly in the UK, where it's given out so commonly that people are almost, not seeing the benefits it were because it's being diffused in a much larger patient population. But of course, the adverse effects are still seen, and they're very commonly known to all of you. Okay, so that's a little bit about MDD. I've concentrated perhaps more on the early stage of treatment. I think there's going to be 2 developments for this for the future. We have one underway, which is a computerized algorithm to guide general practitioners. This is people before the patient comes to the psychiatrist to apply the best evidence. This was stimulated by one of my GP friends asking me why they didn't have such a thing, because in the UK they've got this for treating hypertension and various other things. And we've constructed, and we're doing an NIHR funded study to really guide prescription of antidepressants so they follow the guidelines as early as possible. We do see patients who've gone through sometimes 10 antidepressants, one after the other with little response, and they haven't moved on to referral as early as possible or using drugs which have better evidence of efficacy like vortioxetine. The other thing I think is what I mentioned earlier, the Australian study that John Tiller was telling me about. There's a similar thing in the Mayo Clinic of looking at a way of identifying a subpopulation using biomarkers or other characteristics who would have a much higher chance of success. And I think if you can do a combination of looking at the metabolic profile from the genetic heterogeneity of liver enzymes and so on, maybe looking at transporter into the brain, you may be able to get much more target specificity. Okay, I'm going to talk about bipolar disorder. This is my one slide about bipolar disorder that tells you all the problems. Bipolar disorder, of course, is extremely common. Bipolar 1, bipolar 2, 2% lifetime risk. Another 2.4% lifetime risk for subsyndromal, which merges into major depression. So it's a very common disorder, but very often unrecognized and undiagnosed. Correct diagnosis can take many years. Comorbidities are very common. So psychiatric comorbidities in Merrick Angus's study occur in 75% of patients. So if you actually just look at the non-comorbid patients, you're actually looking at an unusual subset. And physical comorbidities, things like obesity, metabolic syndrome, and so on and so forth, in North America, this is above 50%. The predominant phase is depression, which leads to misdiagnosis. So for about 2/3 of people with bipolar disorder, they'll have 1 or 2 episodes of depression before any sign of pathological mood elevation. There's a retrospective colouring, so if you see a patient who's depressed, they will very often forget the periods of hypomania. It's difficult to miss bipolar 1 because manias a train wreck, but bipolar 2 can be missed. I have a patient who's a family doctor, and the predominant picture is really anxiety, although there is some depression. And after I've been treating her for a couple of years, she had a clear episode of hypomania. I know this because she planned a holiday to Australia. No, that's right. She was hypomanic and she did plan a holiday to Australia, but she was going to take about 12 people. And I spoke to her and her husband and I said, you know, has she ever been like this before? And they went, yeah, she's been like that 2 or 3 times before. I said, but I asked you about all this. And they said, well, you know, it's just the way she goes sometimes. So, and she had real difficulty accepting that that made her bipolar 2. And we then eventually put her on lithium, and she has responded really well to lithium. So you must always beware that the diagnosis of major depressive disorder is provisional, and angst's long-term studies show that they can switch, they can unveil as being bipolar even after decades. What you really need is long-term protection against manic and depressive symptoms, both of them. And there are subtypes, so bipolar 1, bipolar 2, rapid cycling, and mixed states, which I'm not going to talk about too much today, but we've been very poor at characterizing in the past. What about psychotherapies? Well, this is David Miklowicz's work. Many of you will be familiar with this. This looked at a collaborative care group who had, I think, 3 or 4 sessions of therapy contact versus many more sessions of CBT, IPSRT, which is the Pittsburgh group, and family-focused therapy. Now, my take from this, even though the headline result is that these are significantly better, is that any input seems to have a big effect. I do totally buy David's point that there are some, for example, young people living in chaotic households who need a family approach to psychoeducation. There'll be some people who particularly benefit from CBT. I think there's actually some groups who benefit from a psychodynamic approach. But you get an overwhelmingly larger general effect from any intervention at all. And I think this, or some generalized psychoeducation approach, should be offered to all people with bipolar disorder. And then the other therapies should be used in a more bespoke fashion. Psychoeducation undoubtedly works. This is Ed Vieta's latest variant, which is functional remediation, which is basically a group psychoeducation program where they looked at psychosocial functioning as well. I'm a little bit skeptical about this because this isn't blinded. So if you're in Barcelona and you can get the same old psychoeducation, or you can get the newer, jazzier therapy, which one's going to do better? But nevertheless, it does show that both group treatments, which are very economical to give, actually have fairly big benefits. In terms of medication, we have a plethora of different medications for bipolar disorder. I mean, one of the reasons that mood disorders are the happy hunting ground for the psychopharmacologist is we use every single medication that's available and we import others. And of course, the complexity with bipolar disorder is that we have different phases of the illness. So what works in mania, for example, may not work in depression. And the great glaring absence is of trials in bipolar depression. So haloperidol and risperidone, which seem to be very effective in acute mania, in maintenance, certainly haloperidol has been shown quite convincingly to be pro-depressant, and I suspect risperidone is the same. So just because something works in mania, you can't say that about depression. And indeed, there's a number of failed trials in acute depression, which I'll show you and talk about. Now, this is my colleague in Oxford, Andrea Cipriani's meta-analysis. Now, this is a multiple treatment meta-analysis where you can do indirect comparisons in terms of the effects of drugs. So you may have a trial that compares carbamazepine to placebo and asenapine to placebo, and you can then somehow benchmark from asenapine to carbamazepine. Now, there's huge presumptions in that, and one of the best analogies, I think, is actually with sports teams. So I believe Australia just beat New Zealand at rugby. And of course, Scotland have beaten Australia. But you've got to remember that Scotland have never beaten the All Blacks. So there is a real weakness in these indirect comparisons. The other problem with them is people tend to see them, the headline results, as being the gospel truth. So this is ranked for acceptability and efficacy, but this is based on 3-week trials. So acceptability is remaining in a 3-week trial, and efficacy is the efficacy in a 3-week trial. You can see that haloperidol does pretty well. Its efficacy is very high. People will take it for 3 weeks in a trial, but remember the rate of post-manic depression after your mania has been treated with haloperidol is twice with haloperidol what it is for the atypicals. So this doesn't capture the full nuance of the treatments. And you know, Andrea Cipriani would say that, it's all there in the papers, but I've certainly had hospital pharmacists, apologies if there's any in the audience, say to me, well, we should really just have haloperidol or risperidone on the treatment formulary for treating mania. That's nonsense. Moving on to lithium. I'm talking about this much more tomorrow. This is one of the great contributions to psychiatric therapeutics. It was, of course, used very widely in various cures, taken away by the FDA in the 40s and then reintroduced after Cade and Mogan Schou's work in the 50s, 60s and so on. And I think it remains a drug which is extremely useful. Lithium's had a hard time. In the 90s, valproate was marketed against lithium. There's recent evidence published in the New England Journal of Medicine that shows that in actual fact the rate of fetal malformations with lithium is far lower than we thought. There was a recent scare about lithium causing kidney tumours. There were four cases reported from France of people who got renal tumours on lithium. Fortunately, the Danes were able to look at their entire national database of people who were on lithium and also got renal tumours. This captured the whole of the Danish population. There was no increase whatsoever. Probably the long-term effects on renal function remain one of the major issues, and of course adherence and the narrow therapeutic index. But it's a much better drug than some people thought. It also reduces suicide rates, and I'll talk about that again tomorrow. One of the things about lithium is that it was thought to be really only anti-manic, but the recent trials have shown that there is a significant benefit on bipolar depression. That's as monotherapy. And I did also mention the benefits on unipolar disorder, which have been evident for probably a generation, but unrecognized. So what do patients with bipolar disorder want? Well, they want better treatment of depression and they want more tolerability in terms of side effects, and that remains an unmet need. If we look at the more recent drugs, this is the lamotrigine studies. Now again, this is very interesting in terms of the results of trials and evidence. So the first study by Joe Calabrese, who has visited this part of the world, you can see that between placebo and lamotrigine there's really quite a pronounced benefit. GSK then took it forward, and you can see that really there wasn't an overall effect that was particularly significant. It may have reached significance if you pull the data, but it was about somewhere between 1 and 2 points on a depression rating scale. So the initial positive result, now this is not unique to psychiatric trials, it's not unique to medicine, it occurs across the whole of science. John Ioannidis says that, but perhaps we are more vulnerable to being criticised. The initial big positive result gets lost. It's a little bit tough, I think, in lamotrigine, because Joe, in his initial study, did an accelerated dosing scheme that we don't do now. He dosed twice as fast as is recommended. He didn't get any cases of Stevens-Johnson, but remember the time frame for assessment for all of these was 8 weeks. So I think you probably need to give lamotrigine a bit longer time. We also do lamotrigine levels routinely, because there's lots of people who may be on 200 and the lamotrigine level is surprisingly low. The LAM-LIT study was done in the Netherlands. It wasn't pharmaceutically sponsored. And again, you can see if you're on lithium and lamotrigine together, you have a much bigger effect. And that's about 4 points on a depression rating scale. But again, think back to folates and so on and so forth. One positive trial is indicative but can't be definitive unless it's an absolutely enormous trial, which first trials never are. Okay, so this is Olanzapine. This is quite old now, many of you will know this, but this just shows that if you have placebo, you get some benefit. If you have the combination OFC, you have extra benefit. Olanzapine somewhere in the middle. That's not an effect on depression or suicidality, it's an effect on appetite, which is increased, sleep, which is increased, and inner tension, which is reduced. But Olanzapine does have an East Asian trial where the effect size was larger, it was 5 points, and that has led to it getting the introduction, the license in Japan, where it's licensed for bipolar depression. Whether, I'm not quite sure what to make of that. I'm not quite sure whether that's an actual genetic difference or whether that's just a trial where they got lucky, but nevertheless, in non-East Asian populations, the data is still equivocal. Now, you're all familiar with the quetiapine studies, the Boulder and Embolden. It's worthwhile just pointing out that quetiapine's got very good data in bipolar 2 depression. We got into an argument with the BMJ about this because there was an anti-psychiatry GP who said that bipolar 2 was created and it was by pharmaceutical companies who are evil and buy doctors' lunch and so on. And there was no evidence for bipolar 2 either existing or having any specific therapeutic benefit. But quetiapine, lots of the patients in Boulder and Embolden were bipolar 2, and the signal was really very good. You can see here essentially similar effect sizes for bipolar 1. This is lorazepam. This is the other atypical antipsychotic which has data. It's pharmacologically not that different from aripiprazole, but it does have benefits as shown here in bipolar depression. It's reached enough credibility to get the FDA license. It didn't get the license in Europe nor in Australia for, I believe, the same reason, that they didn't have maintenance data that was convincing. We do use this. If you ask me which one I would take to a desert island to treat people on the desert island who have bipolar depression, I'd have to say quetiapine. I think lorazepam is a useful drug. It's got a different range of side effects, but it's probably not as good as quetiapine. And again, you see some add-on data. This is Roger McIntyre showing the effect on subsyndrome. This is just to show it's not all atypical switcher antidepressant. These are the 2 trials with aripiprazole. Michael Thays did this. There's very similar data for ziprasidone. Do you have ziprasidone here? Yeah. I must say I always found ziprasidone a very disappointing drug when I used it in Canada. I think that's because in the trials it's taken after a small fatty meal, which is a bit like a kiddie's McDonald's meal. And they have to have that to increase the absorption. Patients don't do that in real life, therefore it doesn't work as well. But you can see here, there was a separation from placebo, but rather mysteriously that was lost about here, and at the end of the trial, there was no net effect. This has had the effect of the companies wanting to reduce the timescale of trials to 6 weeks, so the effect doesn't, no seriously. This is being poured over by people like Thays, Charlie, Bowden and so on, and they don't think it's because the benzodiazepines were withdrawn here. They think somehow there was a real loss of efficacy, which is really quite difficult to understand. This is ziprasidone. As I say, Mike's, we don't have it in the UK, but I initially used it. No, we don't. It's got to go to Ireland to get it. But I think the absorption difficulties. Remember that antipsychotics can increase depression or dysphoria. This is one of the arguments for not treating all mania with haloperidol, or indeed I would say risperidone. This is nice work from Carlos Zarate in his pre-ketamine era, but you can see the relapse into depression is higher. There's a nice meta-analysis from Goicoechea from Barcelona showing you've got twice the rates of post-manic depression with haloperidol compared to atypicals. So this is one of the reasons for justifying using atypicals, which are now not that much more expensive than the old drugs. What about antidepressants? Well, this is the most recent definitive work. Edward Vieta, myself and others did this. This is the ISBD Taskforce Consensus Report. And it was actually very difficult to reach consensus on anything. So I don't know about Australia, but for the rest of the world, consensus is 80% of people had to agree. And of the 24 experts or so, I think Michael Burke was on the panel. And in actual fact, there were only about 3 or 4 things that we could agree on. There was lots of 70-30, 60-40, but in the absence of evidence, opinion fills the gap. So there's a real gap in terms of using antidepressants or evidence-based, an evidence-based informed use of antidepressants. I do think we need more trials. At the moment, I think we probably overestimated the destabilizing mood effects of what you might call mono neurotransmitter antidepressants. So I think SSRIs on the one hand and bupropion on the other probably do not cause manic switch or rapid cycling more than placebo. In the Embolden 2 study, when we added paroxetine, well, they got paroxetine monotherapy, about 10% became hypomanic on paroxetine and about 9.5 on placebo. I do think tricyclics and SNRIs do cause an excess rate of switch. Of course, tricyclics are associated with rapid cycling. We've used a lot of vortioxetine in bipolar depression despite the lack of any trial, despite Lundbeck not giving me £2 million to do a trial. And we've not got any feeling that there's an excess switch from vortioxetine. Again, it's got a multimodal effect, but it's all serotonin. So I think you've got to hit 5-HT and the catecholamines to have this destabilizing propensity. But, watch this space, that might well be wrong. Okay, there's other things people are using. They're using lisdexamfetamine, modafinil. We're part of a consortium which is going to study pramipexole in bipolar depression. One of the exclusion criteria is people are not allowed to be on antipsychotics, so recruitment for that is going to be very difficult. What about the future and novel treatments? Well, I've listed some of them here. I think modafinil is quite useful. The modafinil trials in bipolar depression failed, but that was probably doesn't obviate the use of modafinil in unipolar depression. Pramipexole is underway. As I say, we have a trial with Oxford and Newcastle looking at this in bipolar depression. It's going to be horrendously difficult to do because they're not allowed to be on atypicals. Michael Burke, who's got a big food and mood interest, which he showed us at a restaurant on Saturday night, has pioneered N-acetylcysteine. There's some very small, interesting small trials. I think the big game changer is going to be ketamine. Now, there's a number of small trials of the infusion. It seems to work in both unipolar and bipolar treatment-resistant depression. Allan Schatzberg did a very wise editorial in the American Journal about being beware of ketamine widespread use because there simply haven't been enough people in trials to judge the adverse effects. And people are worried about the effects on the bladder, dependency and so on. The baton has been taken up by Johnson & Johnson because Husseini Manji went to work for them. They have an intranasal form. I'm not sure if you're doing the trials here. We're doing the European maintenance study. It seems to be very well tolerated, but the important thing is they've got to go through full phase 3 regulatory studies, which I'm pretty certain will show that about 40 to 50% of people with TRD respond, but it will also give us a very good signal of adverse effects. Now you might say ketamine's been around for decades, we must know about adverse effects, but remember it was relatively recently that the Chinese, via the WHO, wanted to ban it internationally because they have such a problem with ketamine abuse. So I think the intranasal ketamine form, which is due to come in the US in 2019, probably due to come to Europe, if Europe still exists in 2020, that's going to be a real advance. And also there's knock-on daughter compounds. So there's already people looking at the AMPA receptor, there's other infusions and other drugs. This may reinvigorate psychopharmacology for mood disorders. The other 2 agents which I think are interesting are minocycline. You're all familiar with the minocycline story in psychosis. We just published a positive trial of adding minocycline to antidepressants, and Michael Burke at the same time published a negative trial. So you would say that's UK and Australia disagreeing. But in actual fact, if you look at the response rates, they are pretty similar. Our effect size was just marginally bigger. The difference is that Michael did his study here, recruiting people for this type of study in the UK, Australia, the US is difficult. You tend to get people with comorbidities, with personality problems. We did our study in Pakistan, where we recruited people very well, low levels of comorbidity, unsullied depression, never treated with anything. We had a much more clear-cut result. The other thing is statins. Michael Burke's produced a nice meta-analysis of 3 small trials where statins are added to antidepressants, to SSRIs. There's a significant benefit. In the Danish database, if you're on statins, you have a much better outcome from depression. The statins, of course, don't just affect your blood lipids, they appear to get into the brain and be anti-inflammatory as well. I'm not sure if that research is going to go anywhere, but I certainly think the minocycline is going to be followed up by other trials. So I think there is potential new mechanisms for the future. The idea that nothing's going to happen is probably not true. Okay, just to say a final word about harms. People talk about number needed to treat, but remember it's always important to think about number needed to harm. This is very, very true. We see, I don't know about those of you who work in mood disorders clinics here, but we see patients who are on many, many treatments. And we saw a lady the other day who was on over 20 medications. Only about 6 of them were psychiatric. And you've got to think about the harm side of this, and especially our adolescent clinic, we see hugely more weight gain in young people. Young bipolars get put on Olanzapine, for example. We see 20 kilograms of weight gain, which is really devastating at that stage of life. So always think about the harms as well as the benefits. So to summarize, mood disorders are common, clinically complex and costly. I don't think we're likely to be out of a job anytime soon if you're interested in treating those. Diagnosis is extremely important and really is pretty much always provisional unless it's bipolar 1 or bipolar 2. Bipolar 1 and bipolar 2 don't cross over very much between the two. But MDD does unveil itself as being bipolar. Of course, there's heterogeneity of symptoms, comorbidity, and so on. Early, accurate diagnosis and appropriate treatment improve patient outcomes. We've got to have restoration of patient functioning as the goal. We've actually, there's a nice paper by Lars Kessing where he did a mood disorder clinic for people discharged from hospital after an episode of mania in Copenhagen, and they were randomized to a mood disorder clinic or to standard care. The relapse rate was much lower in the mood disorders clinic. This was more expensive in one sense because you had professors and so on, very expensive creatures involved. But overall, it's 3,100 euros per head cheaper per patient because of the number of admissions avoided. We've replicated this in the Maudsley Hospital. We're currently writing it up. We actually reduced the admission rate with our optimized treatment clinic, imaginatively called Optima. We reduced the rate of readmission by 80%. And we reduced the use of home treatment teams by 50%. This isn't rocket science, it's psychoeducation, pharmacotherapy, and so on. And lastly, as we should always say, patient involvement in treatment research is a good thing. I'll stop there and thank you for your attention.
Well, we were due to finish 1 minute ago, so does anyone have a question? Perhaps we can do some quick questions.
Yeah, sure.
Questions?
You briefly mentioned mood and food earlier.
Yes.
What are your thoughts about that approach?
I think it's probably going to be very important for a subgroup. Brenda Penix in the Netherlands has a large community study, and she says there's a subgroup of people with depression who've got the more atypical symptoms, It's associated with obesity, and it's associated with increased inflammatory markers. And I suspect, again, you know, Ian Everall and I wrote a paper about, with other people from the department here, about the heterogeneity of depression. I suspect if you did a mood and food approach across the board, you might not find anything. But if you target it to a certain group where it seems to be more tractable, and Brenda's data looks very good that there is this subgroup, that may be the way to go.
Well, it was just a question in Victoria at the minute around ECT. Different groups are trying quite different approaches, ranging from ultra brief, unilateral ECT, and still some units who use bitemporal from, if not the outset, pretty soon afterwards. Just wanted to get a comment about that.
Well, I certainly think it's reasonable to try some of the variants that reduce the risk of cognitive impairment early on, but if people don't respond, they should go on to the old-fashioned bitemporal. There was a nice piece of work from Canada years ago showing bifrontal, where the approach was more anterior, had fewer cognitive effects and the same efficacy. Again, that was just one trial. When I was a trainee, the professor had the old box. This was the old ECT from, you know, the previous machine, and people who hadn't responded would get the old box, and that seemed to work for about 60% of them. I did see a box in the corner of your office, Mal, so I was
All right, well, look, we'll finish up there, and thanks again, Mel, and the University of Melbourne for bringing Allan, and thank you, Professor Young, for a very fine lecture.